right. Hey, there you are. Good. There's a couple of things going. And at the time, I'll see them. Okay, sure. That's right. Okay. You have this. Yeah, I got the sheet right here. Oh, there. Oh, there. It's one of these. I think it's this. Okay, perfect. And remember, Roberto's is in right here.
From your place, right?
Yeah, and his introduction.
Yeah, I saw that. Yeah.
Yeah. Okay, great. Yes. Hello, everyone. We're going to get started with the next session in the interest of time, as well as the interest in serving lunch on time. And so for maybe the latter reason, I will introduce myself. My name is Suhail Hussain. I am a professor of pediatrics and gastroenterology at Stanford University. I'm joined by my co-moderator who will introduce himself and then introduce our first speaker. Just before I pass it off, I wanted to say that each of the speakers in this next session will have 20 minutes for their presentations, and then we'll have 10 minutes for questions. So we should be ending by 10 after 12. And I will put on a timer. You'll have a timer. Each of the presenters will have a timer on the podium. My timer will have a buzzer that will go off. So please try to keep to time. And with that, I pass over to my co-moderator.
Thank you, Sohail. I'm Guru Trikaranath. I'm one of the associate professor at University of Minnesota. I'm an advanced endoscopist by training. And it's an honor to invite Dr. Roberto Guggig. Dr. Roberto Guggig is a professor of pediatrics from Stanford University. He is the director of endoscopy there. He is one of the few who does advanced endoscopic procedures in children. And he has several publications to his credit for that over the last few years. And he is an emerging thought leader in this field. And Dr. Guggig is going to present on EOS utilization from child to an adult pancreas.
Well, thank you for the introduction. Thank you for inviting a pediatric endoscopist to this party. And so I was given the task to present EOS utilization from children to adult. And my first thought was like, are you kidding me? This is quite broad. Nevertheless, I like a challenge. And so I decided to do a search limiting to 1980 when EOS came about. And I had almost 210,000 results. So thank you, my son. If you look at the data, it's incredible that the publications in this area have grown at a rate of about 16% per year. And if you actually digress the graph more, you can see that over the last decade, there's been an explosion of data in this area. So I think I have a lot to talk about. So the next question that I asked Maysam was, well, how much time do I have for this? And she said 15 minutes. Now you're giving me 20, but she said 15 initially. And I said, okay, great. So what I'm going to try to do in this time is talk about why EOS. I'm going to touch upon some diagnostic, therapeutic, and some other applications of EOS. I will touch specifically upon acute pancreatitis, chronic pancreatitis, cystic lesions, and solid lesions. And then again, I will touch upon some enhanced modalities such as elastography and contrast enhancement. So as a little bit of background, endoscopic ultrasound is really an important technology that has many applications and has become necessary component of any advanced endoscopy referral center, with increasingly diagnostic and therapeutic indications. And if you look at the indications, there are established and what we call debatable indications. You can see the pancreas is prominently displayed in these indications. As a little bit of background and history, you can see that 1980 was kind of the introduction of EOS probes within endoscopy. By the late 90s, you had the development of needles and the ability to do FNAs, and then subsequently FMBs. And now we have the ability to do molecular testing. We can do through the scope biopsies and visualization. We can use fine needle aspiration and also core biopsy needles, and even electron microscopy through the needle. So we are now able to do a variety of things through the endoscope. So let's talk a little bit about acute pancreatitis. And I don't need to tell you that EUS is not needed to diagnose this. And furthermore, it doesn't really help in the assessment of severity and stratifying the patients, because we have other indicators and scoring systems and imagings that are much better for this. However, EUS is useful in confirming the debility origin of acute pancreatitis. And when in doubt, it really determines the need or not for ERCP, as EUS has a very high sensitivity and specificity for detection of common bile duct stones. And actually, more importantly, it has a great negative predictive value and greater than MRCP, CT, or transabdominal ultrasound. And in this context, doing EUS prior to ERCP decreases ERCP by about 70% and obviously reduces the complications of post-ERCP pancreatitis. How about acute recurrent pancreatitis? So as stated by Dr. Whitcomb, and this is one of the few times I'm going to say that he was my opening act. In many of the studies in a cohort of patients with acute recurrent pancreatitis with negative genetics, negative imaging studies, if you use EUS, it's been said that about 61% of patients you can find a cause, and 41%, and he presented that data, are biliary tract in origin. It's a reliable method to detect pancreas divisum. And it is somewhat, and I'll touch on this diagnostic technique to identify some patients that already have some features of chronic pancreatitis that are presenting as acute recurrent. And really, it has been determined that EUS is the least expensive initial investigation for the diagnostic evaluation of patients with acute recurrent pancreatitis with gallbladder in place. And usually, you can actually find some interesting things if you look at these cohort of patients. I'll give you some examples. So one is an ascaris that you can see in this patient that had not been identified. Another one is a duplication cyst. And you can find some sludge and microlithiasis within these patients. And really, it helps you try to determine the cause of the problem, the cause of the episodes of acute recurrent pancreatitis. What about chronic pancreatitis? So it's well established and accepted a test for chronic pancreatitis. It's based on 9 parenchymal and ductal features, and it's considered the detection of at least 5 features are considered diagnostic, although I'll talk a little bit more about that. It remains unclear now that EUS and imaging is so sensitive. What are we describing some minor things and how and what they exactly mean, these subtle abnormalities? It remains to be seen how we actually use this or not. And EUS, like any ultrasound test, is very observer dependent, and the inter-observer variability or agreement is not great, and we consider at least a kappa of 0.6. However, when you look at studies of chronic pancreatitis, if you really narrow down the criteria, you can have kappas approaching 0.6 or 0.7 in some studies. And recently, and I'll talk a little bit about this, some enhancement of using elastography and contrast seems to help in some studies with chronic pancreatitis. Now, if you look at the parenchymal and ductal features, and this is what we essentially focus on and look at, and this is some of the described conventional Roseman criteria, which I will say are not validated in pediatrics. And if you look at kind of what the ISGE considers diagnostic consensus for chronic pancreatitis, you can see that this is what we mainly focus on. I think EUS is very good at showing us a very normal pancreas, and it's very good at showing us a fairly advanced pancreas, but somewhere in between, we're not as good. There's been some studies both in adults and pediatrics using functional EUS, using secretin at the time of the EUS and measuring the difference in the dilation of pancreatic duct. that seem to help or at least suggest earlier chronic pancreatitis. We are now in our center trying to combine that functional EUS with at the time measurement of pancreatic function testing and taking bicarbonate and enzymes at the same time and see if that adds to our diagnostic acumen. So more to come, hopefully. And if you look at chronic pancreatitis and the use of EUS, we now have criteria or at least recommendations for both pediatric and adults. This is a recent study with some of the people that are in this room. Unfortunately, because of the lack of data, we use some adult data and some expert opinion. Hopefully, we'll have more data to actually update these guidelines in the future. This study is important because they compared EUS with histology or pathology at the end, and they can actually say that about taking three major criteria or three criteria is the best kind of balance in diagnosing chronic pancreatitis using EUS. There's been other studies using on the role of EUS in chronic pancreatitis. So definitely with all the imperfections that we have, it's still better than the alternatives. And here's a comparison of EUS with ERCP, fecal elastase, pathology, and ERCP. And you can see that EUS, despite its flaws, fares fairly well. So it's the best that we have, I think, for chronic pancreatitis. And this has led to some international guidelines and the use of EUS in chronic pancreatitis. So how about pancreatic cysts? So this is a problem that we see more on the adult side than in pediatrics with improvement in cross-sectional imaging and the fact that everybody that goes to the ER gets a CT scan. We're now diagnosing more cysts than ever, in some studies up to 13.6%. And in general, these cysts are categorized into non-neoplastic, which are true rare cysts, retention cysts, lymphoepithelial cysts, inflammatory cysts, and serocystinomas, and neoplastic ones like mucinous and IPMNs and sort of solid pseudopapillary neoplasms. And these pancreatic cysts have specific imaging features, which means that EUS is really an ideal tool for the evaluation. Furthermore, you can now use FNA, cystic fluid markers, even direct visualization and directed biopsies to help actually identify what type of cysts these are. What about pancreatic masses? And really, EUS was born and created to evaluate pancreatic masses and in the 80s. And you can see that the sensitivity of pancreatic masses compared to MRI and CT is quite favorable. And for smaller lesions, it's even better. But it also has a high negative predictive value on prolonged follow-ups. And I think the biggest or best role for EUS is when imaging shows these enlarged or fullness of the pancreas, where malignancy can be detected in up to 8% of patients. And obviously you have the ability to use FNA or FMB for these masses. This is another area where pediatrics differs from adults in that the pancreatic masses that we are looking at are quite different. On the pediatric side, we're not really worried about malignant cystic masses or adenocarcinoma, but more pancreatoblastoma, neuroendocrine tumors, pseudopapillary tumors, lymphoma, or even autoimmune pancreatitis, more than what you guys see on the adult side. A little word about needle selection. So we have different needles, both for FNA and FMB, and really the needle selection is based upon location. We prefer kind of small needles on the duodenum, the type of lesions that we are going to biopsy, and whether we have therapeutic indication. Few words about FMB needles. It seems that you can do less passes but it has a similar yield to the FNA needles, and it differs where you have in or not pathology in the room. Comparison of smaller needles, and you can see that there's 5 randomized control trials comparing 22 to 25 gauge needles and 2 meta-analysis. And so 25 gauge needles are quite excellent when you're looking at pancreatic masses. A few words about having rapid on-site specimen evaluation. I can tell you what we do is at least on the Stanford on the pediatric side, if we do think it's a malignant lesion going in, we do have pathologists in the room. Otherwise, we don't. So this is a randomized controlled trial comparing having pathology on site or not using FMB needles. And you can see that in the Rose group, they had 3 passes and cytology, and in the non-Rose group, three passes and formalin for histology, but they have similar rates of diagnostic accuracy in both groups. So I think it's more talks about technique and needle selection than whether you have pathology or not. A few words about elastography. So elastography measures relative stiffness on tissue based on the compression, and it produces a collar pattern. I'm sorry, I had some nice videos, but they were not running. So I'll show you a few pictures. And it's superimposed in the B mode ultrasound image, and it's said to improve diagnostic accuracy and reducing the need for EUS tissue sampling, which I think I'll show you is questionable. What is used most is so-called strain ratio that discriminates between normal pancreas, which has a lower strain ratio, and inflammatory masses, adenocarcinoma, or neuroendocrine tumors that have higher strain ratio. As with everything, it's very operator dependent. And if you look at the studies, the strain ratio overlaps between studies. But in a recent meta-analysis that showed the sensitivity, specificity, odd ratio, distinguishing between malignant and benign masses, they actually also calculated the area under the receiver operator curve involving 13 studies and about 1,000 patients. You can see the numbers there. But the conclusion is that it has very high sensitivity, but because the specificity is not as high, you still probably need to consider doing FNA on these patients. So this is what it looks like. And I had some nice videos, but you can see that the marker, but you can see on the left side of that screen is a small mass which essentially has very low strain ratios and stiffness, and on the right side a mass that has very high strain ratios before biopsy. A little bit about contrast enhanced ultrasound, and this consists of using microbubbles in an inert gas surrounded by lipid membrane, and you give that IV. And in most cases, this was developed again on adult studies, mostly seeing if you could differentiate adenocarcinoma because it has hypovascular appearance and irregular network of vessels. And in contrast, things like neuroendocrine tumor, or for us, autoimmune pancreatitis or a lymphoma, have a very high vascular appearance. So there's some early data that suggest that it's been promising. In a recent study from France on 35 patients and comparing to the final pathology, you can see the sensitivity, specificity, positive predictive value, and negative predictive value was, in the high 80% in this study compared to FNA. However, again, it has improved sensitivity and negative predictive value, but low specificity. So again, whether this will totally replace the need to use an FNA remains to be seen. So I wanted to touch upon the therapeutic EUS, and what we use it for pancreas primarily is celiac plexus neurolysis for malignancy and or for chronic pancreatitis. This is important. I wanted to ask Dr. Zing this, so I'll talk to him later, but the response that we see in pediatrics is much better than on adults, and we're actually gathering our data to publish in chronic pancreatitis. I don't know if you have an explanation for this. We use drainage of pancreatic fluid collections. The US is now the main modality of treatment for these. We stage pancreatic cancer, and really has an impact on survival and selecting the best patients for surgery. We do have palliative treatments such as biliary drainage, EUS radiofrequency ablation, tumor ablation, intratumoral drug delivery, radiation, and fiducial marker placements, and even bypassing the stomach to the jejunum when patients are obstructed. So we have a variety of therapeutic indications that are applied to the pancreas, but because of time, I will not go into this. I hear the little voice of only 15 minutes. Now I think I have 20, but anyway, So my take-home points are that EUS is really an essential component in evaluation of children and adults. I think in children, we have the limitation of size, right? But we pediatricians like to MacGyver everything. And so if we can't use the slim EUS scopes for evaluation, we sometimes use bronchoscopes, EBUS to do EUS in children. I've shown you that there's a variety of diagnostic therapeutic applications and even palliative applications, that it is like every ultrasound operator dependent, and there's some conflicts on intra-observer variability, although I still think that it is quite useful, and compared to other modalities, it fares fairly well for the pancreas. And whether these enhance imaging techniques that look promising will change what we do or change the need for FNA or how we practice, I think remains to be seen. So thank you very much.
Thank you very much, Dr. Gugigan. Please do come up to the front.
Next, I would like to introduce Dr. Melina Bellin, who happens to be my mentor as well. She's a professor of pediatrics from University of Minnesota. She has done pioneering research in the field of TPIT, and she's also a recipient of 3 R01 grants and 2 U01 grants, and she's the co-chair of the T1 APDC consortium. And she's going to discuss on diabetes pre and post-surgery in pancreatitis patients.
All right, thank you, Guru, and it's a pleasure to be here again at Pancreas Fest. And as I was preparing this talk, I realized we as the organizing committee gave this a very broad title, and in 20 minutes, it would be very difficult to cover diabetes and acute and chronic pancreatitis and surgery fully, and you'd probably never invite me back to speak if I tried that. So I sort of narrowed this down to a subtitle of selected lessons from largely children and young adults that inform care across the lifespan for diabetes and pancreatitis. I have some disclosures here, and the only ones that are relevant is I do work with some CGM and pump companies on various aspects of research, and I will talk a little bit about continuous glucose monitor use and pump use in diabetes. So I will give a very brief overview to diabetes as it relates to pancreatitis, so-called chronic pancreatitis and related diabetes, or as it pertains to surgery, particularly TPIT, to set the stage. But then I'm going to tell sort of 4 short stories from our work and clinical experience. The first one being about the potential role of autoimmunity or type 1 diabetes and pancreatitis. The second being about clinical management and how we might utilize technology in this patient population. The third is about metabolic stress and how that might affect islet function and islet survival. We know this from TPIT, but I think it may pertain to pancreatitis as well. And lastly, to talk a little bit about what we've learned from young children who are having surgery. So if we look at diabetes and chronic pancreatitis, this is not news to anyone that this is a very common comorbidity of chronic pancreatitis, and that the risk for diabetes increases with duration of disease and age. So if we look at the cohorts that exist here in the US and I think elsewhere as well, if we look at INSPIRE data, about 8% of children have diabetes in the setting of acute or recurrent acute or chronic pancreatitis. And then about a third roughly of adults in a cross-sectional study will have diabetes in the setting of chronic pancreatitis. But if we look at a model of hereditary pancreatitis from the European data, which is the figure up over here on the right-hand corner, we can certainly see this trend of increasing risk of diabetes with duration of chronic pancreatitis and age. And really, you may get different estimates of diabetes depending on what patient population you're looking at, what the disease etiology is, how long they've had it, and what type of interventions have been performed, particularly if there's surgical interventions. So why do we see diabetes in this setting of chronic pancreatitis? Largely, a lot of this is from an insulin secretion defect, or at least that's what we think. This can be due to pancreatic fibrosis or, actual islet loss that occurs with chronic pancreatitis, or maybe even acute pancreatitis, certainly necrotizing acute pancreatitis. But there's also probably earlier stages of beta cell dysfunction that aren't strictly related to islet loss, but related to intrapancreatic inflammation. And we see very early signs of insulin secretion defects by IV glucose tolerance testing and early C-peptide and insulin measures on mixed meal tolerance testing. If we look at patients with chronic pancreatitis, even if they don't yet have diabetes, that may not be the whole story. For some individuals, there may be some component of insulin resistance or reduced insulin sensitivity. And I think we don't fully understand whether there's other hormonal contributors like a role of pancreatic polypeptide deficiency or changes in the incretin axis that occur with malabsorption. The figure on the right here is from the large series out of the United Kingdom of patients who were adult patients who were newly diagnosed with diabetes that was type 2 acute pancreatitis, which is the red, or chronic pancreatitis related, and the time to having to need treatment with insulin therapy for that diabetes diagnosis. So one of the things that really comes out there is that from a treatment perspective, insulin treatment is much more commonly needed in these pancreatitis forms of diabetes than it is in something like type 2 diabetes. Now, in the surgical setting, you've already heard quite a bit about total pancreatectomy with islet autotransplant, so I won't go over that procedure. But one of the things that does happen here when we isolate islets and then we infuse them into the liver for various reasons related to the isolation procedure itself, the inflammation that occurs with the intraportal infusion, and then also the hypoxia that's present particularly early on after islet infusion. We do have a loss of islet mass with that transplant scenario. And so in the TPIAT setting, certainly insulin deficiency is the primary problem driving diabetes. And about 70% of these patients are on insulin in the first couple of years after surgery, and then more long-term. So with that, I'm going to tell you this series of 4 stories, and I'm going to start with observations of autoimmunity in some cases of pancreatitis-related diabetes. And the data I'm going to show you here is largely from patients who have a diagnosis of chronic pancreatitis or recurrent acute pancreatitis. So first of all, this is something that came out a number of years ago when we looked at the first INSPIRE cohort and diabetes in the first INSPIRE cohort. And at that time, we had looked at 400 children, actually excluding those who had surgery. So this didn't include TPIAT patients. And so these 6% of children in the INSPIRE study had diabetes that was thought purely related to the pancreatitis. That was 24 children total, most of whom were on insulin. But what was interesting here is that we had collected some limited data on whether children were tested for islet autoantibodies, which I'll talk a little bit about what I mean by that in the next slide. But they're common markers that are used in clinical practice by endocrinologists for looking for evidence of type 1 diabetes. And in those 13 cases that were tested, actually 5 of them were positive. So often when tested, there was actually a high proportion of patients who seemed to have evidence of type 1 diabetes. And then along with that, we saw other autoimmune diseases more commonly in those patients who had diabetes. And that included things like Hashimoto's, which is very commonly associated with type 1 diabetes, shares similar genetics for autoimmune thyroiditis as it does for type 1 diabetes. So what are these antibodies that we were looking at there? And again, we left a little bit of granular detail at that time on which antibodies were present, and that's something we've added as we've moved along. But this is a slide that's purely from the type 1 diabetes world, not the pancreatitis world, showing the progression of type 1 diabetes. And in individuals who get type 1 diabetes, they're not born with type 1 diabetes, but they are in fact born with a genetic risk. And we have been able to identify a number of those genetic risk factors. And then for reasons we don't understand well, there's something environmentally that triggers the autoimmune process against the beta cells. And that autoimmune process is a cellular driven, a T cell driven process of type 1 diabetes. But the markers that are circulating in the bloodstream that we can easily measure are these autoantibody markers. So they're antibodies that are generated against the beta cell or the islet cell. Now there's the oldest was the islet cell titers, but now there's 4 specific ones that we can measure in clinical practice. And they're present before the onset of clinical type 1 and at the onset, and they do kind of fade with disease. So once disease has been present for a long time, you can have type 1 diabetes, but be antibody negative. So why do we think that this might occur in patients with pancreatitis? What's the interface between type 1 diabetes? And I guess I have an old title here of acute pancreatitis, but I think this pertains to chronic pancreatitis too. So one of the things that is thought to actually precipitate autoantibody development of type 1 diabetes are these neoepitopes, or modifications, post-translational modifications of beta cell antigens. And factors that might drive that include inflammation and oxidative stress, right? So it sounds a little bit like pancreatitis and acute pancreatitis. So we're putting the pancreatitis and acute or chronic pancreatitis in a state that might generate these neoepitopes and make someone who is genetically susceptible more likely to have that environmental trigger. So Dr. Yadav and I had also looked at this from the NAPS2 cohort. And in that cohort saw about a third of patients with diabetes in the setting of recurrent acute or chronic pancreatitis. About a third had autoantibodies. Now, one of our diagnostic challenges here is that if someone's treated with insulin, many of them actually do develop insulin antibodies. I guess they're not autoantibodies, but insulin antibodies. So we have a hard time telling, is that endogenous or is that a result of treatment? So if you just take out the insulin antibodies, you still have about 10% who are positive for other autoantibodies. So there certainly seemed to be a signal here of some immune response against the islets. This is something that we're looking at more closely as part of the type 1 diabetes acute pancreatitis consortium, or the DREAM study, in terms of potentially one of the mechanisms driving diabetes and pancreatitis. So we had also actually observed this clinically in our patients who are referred to our chronic pancreatitis clinic, mostly in patients who are referred for surgery because we're working them up with antibodies as part of their pre-surgical evaluation. So we had this data in that particular population, but some of them actually presented through the medical clinic. And this is a case series we published a few years ago. Since then, we've actually had a few more cases, but cases of patients who presented with positive autoantibodies, and some of them were actually non-diabetic at the point that they presented, but they eventually progressed to diabetes and being C-peptide negative, and clearly seem to have type 1 diabetes. But a few things that stand out here, I think, on this table, is that these are largely young patients. So there are some adults in here. There are a couple that they're in the 40s, but there's a number of children where this was observed, and young adults. And if you think about the natural history of type 1 diabetes, it can occur at any age, but about 40% are diagnosed under the age of 18, and a majority of the others are in their college years or 20s at the time they're diagnosed. It also had a high proportion of PRSS1 patients. Again, we see those patients in greater numbers because they're referred to our surgical program. But if you think about the prevalence of type 1 diabetes being about 1 in every 400 persons, and you have 5 people here with PRSS1 disease, that would be thousands of people with PRSS1 to get this expected prevalence. So it was a bit surprising. We also had the opportunity to look at histology because some of these patients were having TPIT. Unfortunately, we were stuck in this bad conundrum of the islet autoantibodies are there. They're destined to go on to get type 1 diabetes anyway. We're doing total pancreatectomy. What do we do with their islets? If they didn't have diabetes, we tried to give them back. And in most cases, they failed pretty quickly is the sad part of that story. Because they had the autoimmunity there, although that wasn't 100% too. We have a couple patients who still have some islet function. But you could see this on the histology. When they did surgery, you could see this really robust inflammation that occurred around the islets that was very characteristic for the insulitis of type 1 diabetes. So this wasn't just a C-peptide and islet autoantibody observation. This was actually histology diagnosed as well. So that's a really interesting phenomenon that I don't think we understand, but we think may contribute to a very, very small but specific subset, and is important because it might lead to different treatment or interventions. So second, I'm going to talk a little bit about treatment of these patients and what is the role for newer diabetes technologies in treating these patients. And I'm going to use data from TPIT because I think that's the only place where we really have this type of treatment data right now, at least in children and young adults. And I'm going to talk about the pediatric population mostly, but I think that these therapies, these technologies are somewhat underutilized in the adult population and that they pertain to adult TPIT and adult chronic pancreatitis. So diabetes technology has really advanced over the past decade. So we've had pumps, insulin pumps for a while, but the continuous glucose monitoring technology and the integration of CGMs and pump technology have really advanced. So right now in our TPIT program for our younger patients, our kids and our adolescents, really our standard care is to put them right on pump therapy and CGM therapy very early after surgery. And it's wonderful in terms of the precision of control we can get as a medical provider. It's wonderful for the patient in terms of their patient satisfaction with these devices. Instead of giving individual shots, they're wearing their technology and insulin around with them all the time. It is not less work. I always tell patients that. It is just there's a certain convenience to that, to having everything with you and being able to do that precise dosing. And as providers, what's actually really nice for us is we can see something like this. This is a graphic we get from one of our systems for pumps and CGMs that actually shows you what it's showing you here is continuous glucose monitoring across the day. And every time there was a bolus in the pump, you see exactly what's happening across the entire day. So CGMs are actually really standard of care now, I think, for diabetes, including both our kids and adults who have TPIT. Unfortunately, less so in the chronic pancreatitis population, although I think they should be standard of care for people who are on insulin therapy. But a number of years ago, when these were not quite yet standard of care, and Dexcom G6, which is one of the most widely used, was just coming out, we looked at this early after surgery just to demonstrate what would the role be. And we did this in kids up to the age of 21 who wore a CGM device that they either saw the readings or they didn't. So it was either blinded and they were just relying on meter, or they could actually get that information from the CGM. And we did see a difference in the glycemic control in those patients who were able to see their numbers. So patients having access, not surprisingly, to what their body is doing, what their numbers are, actually benefits control, and we're able to get tighter control, which we really value early after CGM or after TPIT for engraftment. We also were able to look at what happened if we put kids on pump therapy right in the hospital. So I think, speaking for all of the pediatric centers that do TPIT here, I think this is actually really standard of care now for kids who have TPIT, is that they go onto a pump right in the hospital after they come off the insulin drip, but it wasn't always. A number of years ago, hospitals did not like to do new pump starts inpatient, and patients were put on MDI, multiple daily injection therapy. And when we first started switching over to pumps, and this was with a learning curve, so it's even better now, but when we first started switching over to pumps, we looked at these patients who were going straight to pump. They had less, it's not truly severe hypoglycemia in the sense they didn't have any reaction, but they had less numbers that were less than 54. They had less severe hyperglycemia above 180. And actually, there's something that's more effective about the insulin delivery on a pump system, and this is true for type 1 too. So patients used 30% less insulin if they were on an insulin pump. And patients and families were much happier. So this is from the Cincinnati group, who is also showing similar findings. So I just wanted to highlight that their group has published on this as well. And it's subtle, but there's just less variability and ability to titrate to more precision and make changes quicker when a patient is on a pump. I'd love to see this moving into more of the adult standards of care too. We actually sometimes have trouble getting adult endocrinologists willing to prescribe pumps after TPIT when we send patients back home, which I think is unfortunate for reasons that don't make a lot of sense, like the patient isn't using enough insulin to do that, because you can get very good control. So the next phase in this is actually the integrated pump therapy, which we've been working with more recently. This is an older study that used a fully automated closed loop pump system where the CGM entirely controlled the pump, but it was an experimental system where we designed the algorithm and had to do some calibration of the system. But what we did see in these patients is that those who use this experimental fully closed loop pump system had better glycemic control than all of the patients who were on at that point in time was MDI therapy. So I think we have a lot of potential to expand this use of diabetes technology. Last couple of things, which are much more brief. I want to just tell you a little bit about metabolic stress in TPIT. Metabolic stress as it pertains to islet health specifically. So insulin, for those who maybe don't think about insulin as much, it is actually formed as a proinsulin molecule, and then it's cleaved into C-peptide and insulin. And under conditions of chronic glucose stimulation, inflammation, lipotoxicity, you can actually get misfolding, chronic stress and misfolding of this proinsulin molecule that leads to ER stress signaling. And this was initially described in type 2 diabetes, but is now recognized to pertain to other forms of diabetes where there's chronic glucose stimulation, including type 1. And actually, leads to islet apoptosis and islet loss. So when we look at the TPIT population, we're looking at this at a much larger scale in that long-term study that we're doing right now. But when we looked in a smaller scale, patients who had evidence of this ER stress marker, insulin misfolding, so elevated proinsulin to C-peptide ratios, or a similar marker that also reflects insulin misfolding, those individuals were more likely to remain on insulin, whereas patients who eventually became insulin independent early after surgery had lower markers of metabolic stress. Unfortunately, right now in the TPIT setting, the only way we can really address this is really tight glycemic control, but we do try to limit hyperglycemia for this reason of not wanting to induce islet stress. But I think this is something that's just not been studied at all in chronic pancreatitis and would be very interesting to look at. So lastly, just a little bit about islet function and insulin independence in young children, because this is something that we've observed for quite a number of years and I've always found very fascinating, although I don't think we fully understand the mechanisms here. But if you look at kids and adults over time, there's actually different rates of insulin independence, and kids are more likely in general than adults to actually come off insulin. And I think this is going to hold too in the post study, which we'll hopefully present this fall. But if you look at this a little bit more closely and you divide those kids into young kids and teenagers, you actually see this is driven by these kids who are really young. So these are driven by kids who are about 3 to 10 years of age, who really have superior insulin independence outcomes. I just have one slide left, so we're good. So then if we look at actual islet function measures by mixed meal tolerance testing, and this is going to be published in the very near future. This is from 360 tests of islet function. We see this true with the islet function measures as well. So they sustain the C-peptide production from the islets more robustly over 4 years in the young children group. So in conclusion, I think these are some takeaways that we can learn from our research as largely in children and young adults with pancreatitis and diabetes and TPIT. We should think about this role of autoimmunity, not only on a research setting, but if you have a patient who presents with pretty rapid onset of diabetes and hyperglycemia, think about this. It may have different treatment implications. We should think about expanding our use of technology, our quote unquote type 1 diabetes technology in this setting. Look a little bit more into whether metabolic stress is also a factor in pancreatitis related diabetes and expand that research in TPIT. And there's something really interesting in these young kids that I think we can learn about, maybe a more resilient factor in these young juvenile islets. So with that, I just want to acknowledge the team, and I will wrap up here and we can take questions.
Great. Thank you, Dr. Bellin. This is now open for Q&A, and there is a roaming microphone right there. Yes, please. Please introduce yourself.
Hong Jin Wang from Medical University of South Carolina. We do TPIT as well. I have a question for Dr. Berlin, Melina, because usually we recommend every single TPIT patient to have insulin right after surgery. So if you use pump for this patient, are you giving pumps to everyone? And if they don't need it later on, how do you wean it off? Like we discussed, we have patients who get 1 million islets. They still suggest to give them 20 units of insulin. They get hypoglycemia. I think pump is a great idea to avoid that.
Yeah.
So how do you?
So we, that's a great question. So as a general rule of thumb, we keep everyone on insulin for at least 3 months. So though the reality is most are on more like 6 months to a year, because we're very careful to avoid hyperglycemia. And so my particular practice is after 3 months, if glucose control is stable, I start slowly cutting back. You can do that on a pump as well as a sensor. I'm not quite sure how to do it with the closed loop pump systems yet, because we're kind of just starting to use those that early after surgery, but some of them seem to kind of auto wean on the closed loop pumps where the CGM is feeding the data. But yeah, it is a really nice way to be able to adjust insulin therapy. What we liked about in the hospital is you could adjust really quickly. Because sometimes we see really rapid changes either in the patient health or in the even something like the nutritional status, like something about tube feeds had to be changed or a formula was changed. And on basal insulin, you're kind of committed to your insulin dose for 24 hours, and you can make a near immediate change with pump therapy to your insulin dosing.
Great, thank you. And just as a time check, we have until 10 after the hour I'm sure no one wants to miss out on lunch. So please,
I'll try
let's
to
take
be
maybe
quick.
2 or 3 questions and rapidly. Thank you.
Veronique Mornville from Montreal. Thank you to all the speakers. This fantastic session. This was to add a little bit to what my son was saying. The Inspire Consortium, of many in the room are members of, which studies acute recurrent and chronic pancreatitis, has a cohort. And we looked recently, which was recently accepted for publication, at what we call the drug-associated pancreatitis. Obviously, I think it goes to the notion, if you check for things, you will find things, which is partially what you were saying, that your cohort that you looked at Cincinnati for single episodes, once you start to look for other risk factors, a lot of these children seem to be predisposed to pancreatitis. Obviously, in Inspire, children are even more pre-selected, so it's a biased group, and we only had 51 kids out of 726. But even in that cohort, there was more than 60% that had at least one acute pancreatitis without any medication exposure. Some of them have had recurrent attacks of acute pancreatitis over the years with different medication exposures. And many of them had other systemic risk factors, genetic risk factors, if you searched for it. So then scores such as Naranjo was very poor at delineating that the drug was the risk factor. And I think for a lot of them are the causative reason. And I think probably in adults, there would be similar findings, especially younger adults, where other risk factors such as genetics seems to be particularly leading to someone being at risk for pancreatitis. And then the medication, yes, for things like asparaginase can be a big factor, but I think for other medications becomes one of an additive risk factor. Any further comments? Thank you.
Thank you, Aaron. No,
I think you have to turn it on.
maybe that would work.
Right. All right. I agree with you totally. And the reason I mentioned that index AP is a reasonable example to study drug-induced pancreatic injury, because even in the index AP, it's very challenging because we do not have appropriate causality assessment tools. But at least you could say you haven't had the problem for years, and where genetics in children is about 80% or so of the cohort when you extensively genotype them. So then that becomes more of, did you really have a drug for years? And that is a drug-induced pancreatitis. When you have recurrent and chronic, it's hard, but maybe they did.
Hi, Mohammed Khan, Columbus, Ohio. Roberto, I don't want you to feel left out. So I'm going to ask you a question. US guided sampling. You were talking about pathology assisted on-site exam. Do you have any opinion on macroscopic evaluation without the pathologist, now that we have fine needle biopsies that take really nice course?
Can you repeat the question? So endoscopic evaluations?
So yeah, you know, like traditional approaches to use the pathologist in the room when you're doing your US guided biopsies, and that was typical in FNA. But now with FNB and we can get good cores, now kind of the trend is more towards macroscopic evaluation, just looking in the container and saying, yes, I got a good sample. You know, what are your opinions, thoughts?
Yeah, I mean, so I guess my biggest example in pediatrics, right, where we've had a lot of problems was autoimmune pancreatitis. On the patients that we selected to biopsy using FNA and we sent it to pathology, we usually got this mismatch of results, right? Non-committal, I find this, I find that. They describe, you know, clinical correlation. So we're not as good, and we just put a needle in a patient. So we decided to have then cytopathology in the room. But then when we move to FMB and we get better cores, we have not needed them in the room for that particular reason. I think for malignant or suspicious of malignant, now with the FMB, you can see that the literature shows that if you it's similar whether you have pathology in the room or not. So I think if you have good technique and good core, you should be able to make the diagnosis without any problem. You may have less passes with the core, that's all.
Two quick questions. One is for drug-induced pancreatitis. Is Sohail and Malsam. Our mechanistic understanding is really bad for drug-induced pancreatitis. Maybe the most work has been done on asparaginase, but even there, it's very contentious. So you would expect if these are true associations, then you give mice the drug, they get pancreatitis, and that hasn't been the case for the most part. And then a quick question to Melina, that the association with PRSS1, your explanation is that acute pancreatitis drives onset of type 1 diabetes. Did I get that right?
I'll answer that latter question first. Yeah, this would be, and obviously just a hypothesis, but this would be my hypothesis, is that those episodes of acute inflammation and that acute inflammatory environment is making the pancreas more susceptible to that autoimmune. We don't know what those environmental factors is. And I guess the proposal is maybe that's one of those environmental triggers for those who are genetically susceptible.
And to start answering your question real quick, and then I'll have Sohail comment. I totally agree with you. That's the short answer. We don't know, but to keep an open mind to this black box, we have to think of susceptibility and then mechanisms. So susceptibility, you would have, like I showed, pharmacogenomics, and then even genetic risks that we don't know. And then there's the mechanisms by which it leads to the injury. And I would stop here because we do definitely need to probe the problem through the right pathways.
And, I agree. This is a fascinating topic. There needs to be so much more done. I think there's insight into biology for other types of pancreatitis as a result of this. Each particular drug may be different. For example, thiopurines, the genetics behind thiopurines may be distinct. Whereas when you saw my some slides for asparaginase, notwithstanding the relatively low quality of the genetic studies because of low numbers, most of the genes that were identified, at least on first pass, do not seem to be related to the drug itself. It's not about the metabolism. It's not about some sort of distinct factor. It's pancreatitis susceptibility. And so each drug is different. The common theme seems to be that the drug by itself does not cause the problem, but the convergence of multiple risk factors leads to the problem. And that's probably why the mouse does not develop a pancreatitis with asparaginase, even though there are some perturbations such as in calcium, et cetera. And with that, let's, and thank you very much to the speakers and to each of you.